So we've got some big news from United Healthcare. They're restricting RPM coverage to heart failure and pregnancy only. And this is effective January 1st, 2026. So here's why it matters. If you're billing for RPM, hypertension, COPD, diabetes, your claims are going to get denied starting January 1st. And if United Healthcare is a significant payer for your practice, you're going to need to audit your remote patient monitoring panel immediately. So the weird thing is that unlike CMS, which is expanding remote care through new models like APCM, UHC seems to be moving in the opposite direction. They're adopting a strict proven versus unproven model that effectively eliminates RPM coverage for the vast majority of chronic condition patients. So the new standard for UHC is now only things that are proven a medical necessity. So starting in January 1st, UHC will consider RPM proven and medically necessary for only two conditions. And that's heart failure and hypertensive disorder for only pregnancies. So for almost every other chronic condition, including type 2 diabetes, hypertension, COPD, anxiety, and sleep apnea, UHC has specifically flagged these conditions as unproven and not medically necessary. So what's the bottom line? What does this mean for your revenue? So if you're currently billing codes 99453, 99454, and 99457 for UHC patients with diabetes or standard hypertension, you face a high risk of automated denials beginning January 1st. So the reality is that this policy change is really aggressive, but it's also manageable if you act before the deadline. Here's a couple of things you need to do. Number one, you need to identify every single UHC patient you have that's currently on RPM. Number two, you need to verify if they have heart failure or hypertension during pregnancy or pregnancy diagnoses. If they don't, you need to transition their care to chronic care management programs at least by December 31st. Otherwise, you're gonna have revenue disruption. So I didn't just come with bad news. We do have a solution. FairPath can automate these rules that are changing. And here's how we do it. Reading the policy is one thing, enforcing it across 2,000 patients is completely different. In FairPath, our payer ontology now reflects the 2026 UHC restrictions and automatically cross-references payer, diagnoses, and program. So teams know where RPM is and is not covered. Patient records are evaluated against the updated UHC policy logic inside the payer ontology. When a UHC member is tied to a non-covered diagnosis for RPM, the enrollment surfaces as not covered within FairPath. That leaves clinicians to be able to redirect those patients to CCM and APCM immediately, establishing pathways without wasting setup time or billing attempts. The reality is that the UHC shift is a big deal if you have remote care in place. FairPath is here to help. Visit us at fairpath.ai to learn more.